Welcome to our Advances in Dementia Research webinar series. My name is Julie Wong. I am one of your co-hosts today. This webinar series is presented by the Toronto Dementia Research Alliance in partnership with the Alzheimer Society of Toronto. This series discusses recent updates in dementia research and highlights dementia research studies that are occurring across Toronto. A little bit of housekeeping for you. I am going to ask that you keep yourselves on mute. Please feel free as the session is happening to submit your questions throughout, and we'll try to answer as many as we can at the end. This session is being recorded and it will be posted on both the AST YouTube channel as well as the TDRA website. So as such, I am going to ask that you refrain from posting any personal information in the chat. So a little bit about AST for those of you who are not familiar with the Alzheimer's Society of Toronto. The Alzheimer's Society of Toronto provides information, education, and support to people who are living with dementia and their family and friends, healthcare professionals, as well as the general public within the M postal code. Even though we are called the Alzheimer's Society of Toronto, we service all dementias and its diagnosis is not required to access any of our programs and services. Our services are offered in person as well as virtually through Zoom, and we also provide some education and services through the ALZ Educate e-learning platform that is run by the Alzheimer's Society of Toronto or Ontario. To learn more, please visit our website at www.alz.to and take a look at our calendar of events for upcoming offerings. I'd now like to introduce to you my co-host, who is from the TDRA. Established in 2012, the Toronto Dementia Research Alliance, or the TDRA, is a collaboration among the University of Toronto, Baycrest, the Centre for Addiction and Mental Health, Ontario Shores Centre for Mental Health Sciences, Sunnybrook, and the University Health Network. Together with its partners, TDRA aims to strengthen the link between basic science and clinical research to better understand, prevent, and treat dementia. So I'd like to hand it to my partner, Natalie Dren from the TDRA, to tell you a little bit more.
Thanks, Julie. Hi, everyone, and thank you for joining today. If we can just move to the next slide. Okay, so as part of our education and community outreach, AST and TDRA created a research studies section on the Toronto Dementia Network website, or what we call the TDN. This section lists dementia studies that are open for participation in Toronto and at TDRA partner sites. All the studies listed are led by TDRA affiliated scientists. They're approved by what's called a research ethics board, and they're explained in easy to understand terms. So you can connect directly with the study teams to express interest and find out if you're eligible for any of the studies. There are studies for people living with dementia, mild cognitive impairment, those at risk for dementia, caregivers, and healthy volunteers. And for more information, you can visit the website shown here in orange or in the QR code that's on the screen. I will also post the website in the chat so you can have a look. So we can move to the next slide. And on the website, there are two main pathways. First, you can browse for a study on your own, and when you find one that you're interested in, you can fill out the contact form to be connected with the research team, and they will enroll you in the study if it's something that you're eligible for. Or at the bottom here, there's, if you're not exactly sure where to start, you can fill out a questionnaire and someone will help match you to a study. And any of the information that you enter on the website will be securely stored and protected. Next slide. Okay, and this is what the website looks like. So to find studies, you use the search bar at the top. You can type a keyword like agitation, apply filters, or do both to narrow down your search. Or you can use the quick search buttons in the blue boxes. And like I said, if you're not sure where to start, you can fill out a questionnaire and someone will help match you. And to do this, you click the Match Me to a Study box, which is in orange, or scroll to the bottom of the page where you'll find an orange button that says can't find the study you're interested in. So both of those options will take you to the questionnaire. And each study summary, as shown in the comment study box on the right, describes what the study is about, who can participate, the location, and the time requirement. Again, that's all in plain language. And the COMET study is being discussed here today, and it's actually listed on the TDN. So you'll be able to read more and connect to the study teams there if you wish. And that's it for the TDN. We'll go to the next slide. And I just wanted to quickly flag an event happening in August or in July 2025 in Toronto. So it's called AAIC for All Community. And this is a free event happening on the last day of AAIC, which stands for the Alzheimer's Association International Conference. And that's the largest international dementia conference that happens annually. And this year it's going to be in Toronto. So this day is specifically designed for the public. So people living with dementia, care partners, family members, or really anyone who's interested in learning more. The program is now available online, so you can check out the agenda if you're interested, and you can attend in person at the Metro Toronto Convention Centre or join online, either live or by watching the recordings after. There's also a separate clinician track happening at the same time. So if you're a healthcare provider or researcher who is tight on time but wants to catch the highlights, that's a great option too. You do need to register to attend, but it's completely free. And importantly, you don't need to register or pay for the full IC conference to take part in either the community or the clinician day. So it's a great opportunity to learn more. There's a QR code on the slide that will take you right to the registration page, and I will also put the link for that in the chat box so you can sign up directly. And the next slide. Okay, and then right after the AAIC for All Day wraps, TDRA is co-hosting a complimentary social with the Alzheimer's Society of Toronto, and it's going to be held from 1:30 to 3:30 at Elephant and Castle, which is just a 7-minute walk from the Metro Convention Centre. It is a free event, and we will have complimentary snacks and refreshments for everyone. And the goal is to just kind of create a relaxed space where people can all connect, chat, and learn from each other and each other's experiences. So again, QR code is on the screen, which you can scan to register. And I will, again, put the link for that in the chat. And we can move to the next slide. Okay, so I'm pleased to welcome Dr. Krista Langtoat, a senior scientist at Sunnybrook's Hurwitz Brain Sciences Research Program and director of the Geriatric Psychopharmacology Research Group. She holds the Burnick Chair in Geriatric Psychopharmacology and is a professor of psychiatry and pharmacology at the University of Toronto, where she also serves as vice chair of basic and clinical sciences. Dr. Langtoat's research focuses on understanding and treating mood, cognitive and behavioral symptoms in conditions like dementia and stroke, with the goal of developing safer, more targeted treatments. So welcome, Dr. Langtoat, and we're so excited to have you with us here today.
Thank you so much. I'll just share my screen if you want to bear with me for a moment, and then I want to put it in presenter mode. Okay, thank you very much. So you already heard the introduction. I want to start by giving you a few disclosures. By way of disclosure, I've been a consultant, or I'm on the advisory board for several drug companies, but the research that I'm going to be presenting for you today comes from peer-reviewed funding. So it's granting agencies, not from drug companies. Just to give you an outline, most of this presentation is actually just a general overview talking about agitation and its importance, and a background on cannabinoids and the evidence to date. And then we'll have a little bit on the COMET trial that's being run. And this presentation is going to be presented as much as I can in lay language, and there will be time for questions and answers afterwards, because I'm trying to, aim for a really big group of people with different backgrounds. So I guess nobody will be happy with the presentation, but that's why we have Q&A afterwards. You can ask anything that you want that I don't explain properly, or if you want some of the more in-depth statistical details of some of the research that I present. So dementia in Canada, as we know, the number of people with dementia in Canada is growing. Right now, we're a little bit over 600,000, but by the time we reach 2030, we'll be at 1 million. And by the time we reach 2040 and beyond, we'll be at 1.7 million people. And the most common cause of dementia in Canada is Alzheimer's disease. And the reason why these numbers are getting bigger is because we have an aging population in Canada. So the more older adults you have, the higher the number of people who will have dementia. And today we're focusing on agitation in persons with Alzheimer's disease. So I didn't always spell that out. PW is persons with, and AD is Alzheimer's disease, one of the most common causes. So how do you diagnose agitation? In persons with Alzheimer's disease, there's diagnostic criteria, so criteria that are written out so that physicians and clinicians and people, families and their care partners can use. You have cognitive impairment or dementia in this case. And the main part of it is that you have excessive motor activity, verbal aggression, or physical aggression. And these behaviors have to be associated with distress. For it to be important, it has to have excessive disability beyond that from the underlying cognitive impairment. And before we call it agitation in persons with Alzheimer's disease, you have to make sure it's not attributed to your underlying medical condition, like you have an infection or something else going on, or environmental conditions that you're agitated because of, you're sharing a room with someone else and, they're contributing to your agitation. So the three key domains of agitation are excessive motor activity, verbal aggression, and physical aggression. And I'm just showing you here how we would measure it, for example, in a clinical trial. These are the behaviors and changes that we would look for. So excessive motor activity would be pacing, rocking, gesturing, pointing fingers, restlessness, and repetitious mannerisms. For verbal aggression, just like you would think, yelling, speaking in an excessively loud voice, using profanity, screaming, and shouting. And for physical aggression, it can be against others, grabbing, shoving, pushing, hitting others. It can be against objects, kicking objects, throwing objects, slamming doors, or destroying property. And it can also be against yourself, so hitting yourself. Key to this is that it has to be associated with emotional distress. That's the difference between happy wandering and pacing and going for a walk compared to the pacing that's associated with agitation. There's emotional distress involved. The behavior has to be persistent or at least frequently recurrent for a minimum of 2 weeks. And it's usually much longer than that before people come in to see us. So here's my polling question one. Now that I've shown you, agitation and the diagnostic criteria, at any given point in time, what percentage of people with Alzheimer's disease do you think would have agitation? Would it be 20%, 30%, 40%, or 50%? And Natalie or Julie, can you launch that poll for me? I don't see it. There it is. Okay, thank you.
Are you able to see the results, Krista?
Yep.
Perfect.
So I think most people have had a chance to answer it. So I'll end poll and share the results for everyone. It looks like most people picked between 30, 40, or 50%, and the most common answer was 50%. I have to switch back to slides. So agitation is common in persons with Alzheimer's disease. This group was absolutely right. In this meta-analysis, so an analysis of 48 studies in Alzheimer's disease, at one point in time, about 40% of people across various studies are expected to have agitation. And you can see here are all the behavioral changes across the bottom. And only apathy and depression are more common than agitation, and it's similar to anxiety, sleep, and irritability. And the reason why we have this big range is because the frequency of agitation varies by the population you're looking at and by the setting. So it starts with about 10% of people who have mild cognitive impairment. By the time you're presenting to a memory clinic, about 15% of people will have agitation. For people with dementia living in the community, about a third. And by the time you have moderate to severe Alzheimer's disease, or if you're living in a long-term care facility, that gets as high as 50%. So the other reason is that you tend to have more agitation with greater cognitive impairment. And you can see in this graph, very mild cognitive impairment, about 10%. And by the time you're severe, it's almost at 50%. So there's a greater odds of agitation. You have 5 times more likely to have agitation if you have mild compared to very mild, and you're 6 or 7 times more likely to have agitation by the time you're moderate to severe. And we've found from research that the severity and the percent of agitated people is equal in males and females. So sex does not matter. Once you have it, though, it tends to be persistent. You can see from this graph that here's your agitation score. Higher means that you have more agitation, and over time, agitation scores get higher. So in this study, they looked at people with any agitation, and they found that at baseline, it was 52%, but if you follow them for 3 years, the same group, it's 60%. And people with kind of high levels of agitation, on this scale, that's a score of at least 4. Those are the people who would typically meet those diagnostic criteria for agitation because it would be interfering with their life. Starts at 15% and moves to 23% over 3 years of observation. The problem with agitation is it has a negative impact on the person with Alzheimer's disease. So with persons with dementia, it's associated with a decreased quality of life, like you would expect given the emotional distress, increased risk of health problems like falls and weight loss, a faster rate of functional decline, and an increased risk of mortality. And for the care partner, it increases caregiver burden. It increases their informal costs of caring for that patient. It's a big predictor of institutionalization. And if the person is institutionalized, it becomes a principal concern in the long-term care facilities. Because of its high prevalence and because it has this negative impact, it's a target for both non-pharmacologic and pharmacologic interventions. So by non-pharmacologic here, I'm referring to psychosocial interventions, and that's always what you do first. You try to have a psychosocial intervention, and there are various activities that have been shown over time to help with agitation. In this review, music therapy and sensory interventions like massage and therapeutic touch were found to be the most have the most efficacy, the most benefit for people with agitation. But they lack long-term benefits, and they have no effects on severe agitation. They work better for mild to moderate. So the next step, if you have severe agitation, would be medications once these psychosocial interventions are in place. Unfortunately, the drugs that are prescribed for Alzheimer's disease that help a little bit with cognitive impairment do not improve agitation. They may help delay emergence of agitation over time as you get more cognitively impaired, but that once you have agitation, they don't really help that much. Other drugs like antipsychotics have modest efficacy and or severe side effects in some persons with dementia. And I just highlighted the word efficacy here to remind me to tell you that there's a difference for a pharmacologist. It can be your word of the day between efficacy and effectiveness. Effectiveness is when you go to a physician and they give you medication and they ask you whether it helps or not. But efficacy in this context is a little bit different. It means that it's been proven to improve that behavior or that symptom in a randomized placebo-controlled trial. So efficacy means we know it really works, that it's not just other changes and other contributors that are making it look like it works. So that's efficacy in a clinical trial. So right now there's an unmet need for the treatment of severe agitation. The non-pharmacologic interventions are here on the safety side because they're very safe, but they have limited efficacy for severe agitation, and they're actually quite difficult to implement and to keep up. Pharmacotherapy or drugs are on the efficacy side, but there's no medications that have this efficacy that are also safe. So that moves us on to the next section of what I wanted to talk about, and that's just the rationale for using cannabinoids. So the most widely used cannabinoid around the world is cannabis. Cannabis is the cannabinoid that you've all heard of. And you can see that in cannabis, there are 483 active compounds, right? But the two major ones that I think we've heard of are THC and CBD. CBD standing, of course, for cannabidiol. THC is the one who causes the high, so it's psychoactive, and CBD doesn't cause a high, but it still goes into the brain and it's psychotropic, even though it's not psychoactive. So it still has an impact on the brain, even though you don't typically get the high from it. So your body has receptors for cannabis and cannabinoids all over the body. They're called CB1, cannabinoid receptor 1, and CB2. You can see CB1 is the blue one. It's all over the body, but it's mostly in the brain. And CB2 is the reddish one, and it's mostly involved with the immune system, but it is also found in the brain. And this is just a brain picture that shows you the sites of THC, one of the compounds, action in yellow dots. And you can see that it binds in areas associated with memory, reward, judgment, movement, sensations, and coordination. So THC, the one component, directly stimulates the endocannabinoid system. So it binds to those yellow receptors. And because of that, there are some possible benefits you could have. You could have sedation. It's dose related. It could be mild, but if you have too high of a dose, it could be too much sedation. It has anti-anxiety effects. It can increase appetite. We know appetite, when people are agitated, they don't sit and eat, so they lose their appetite and they tend to lose weight. So that might be good. And it can decrease pain. We know that untreated pain can be one of the causes that contributes to agitation. It also may have an impact on brain health. So protecting your neurons, neuroprotection. And there's a variety of things that are listed here that we think go on in Alzheimer's disease that cause you to lose brain cells, like inflammation, excitotoxicity. Mitochondrial dysfunction just means the powerhouse of your brain stops working. And oxidative stress means that when the powerhouse of your brain, the mitochondria, are working, they create reactive oxygen species. Your brain usually mops those up, but it reaches a point where you're making too many and it can't mop them up fast enough. And then you start losing brain cells because of that. So those are all important mechanisms in Alzheimer's disease. For CBD, it doesn't directly bind to the system, but it modifies the endocannabinoid system. So it also has possible benefits. Again, it's sedating and anti-anxiety effects. It works as an anticonvulsant. Unlike THC, we can actually increase your risk of convulsions if you're susceptible. And it works as an antipsychotic. So instead of causing delusions and hallucinations, like sometimes high doses of THC can, it does the opposite. It helps. And it has some of the same benefits on brain health. Neuroprotection, meaning it protects the brain. So again, it would be important in someone with AD, Alzheimer's disease, that it has those effects. But like everything, if it works, it actually has to have side effects as well, right? So here are some of the side effects we see with cannabinoids: dizziness, lightheadedness, fatigue or drowsiness, withdrawal symptoms. Your coordination can be impaired, mental health disturbances like anxiety and depression, cognitive disturbances because it can make interfere with memory, and especially in people who have Alzheimer's disease, and increase your heart rate and blood pressure. So it has cardiovascular side effects. So specifically in older adults, you might, and other adults as well, you would worry about driving because it affects your cognitive abilities and your motor abilities. You would worry about falls, particularly in older adults, because it affects your coordination and balance. And then on top of that, it can give you dizziness and drowsiness. And because it can interfere with other medications, and older people are on a lot of other medications, it can interfere with how your body clears those medications. So let me ask you a polling question too. This is like an exam. So THC is not thought to be an analgesic, an anxiolytic, an anti-nausea, or an antipsychotic. So what do you think THC doesn't do? It looks like most people have had a chance to do this. So I'll end the poll and share the results. And this class gets an A because antipsychotic was the right answer. THC is not an antipsychotic and it can increase psychotic symptoms. It is on the market as an anti-nausea medication. I didn't present that to you. And it also can be an analgesic and an anxiolytic. So that's one of the differences between THC and CBD. So what's the evidence to date for using cannabinoids for agitation and Alzheimer's disease? One of the first studies was run by my group, and it was a pilot study. We used nabilone, and nabilone is just a synthetic THC. So it's THC in a capsule. We ran a small crossover trial in just 38 persons with agitation who also had Alzheimer's disease dementia, and they got both of them. Because it's a crossover trial, they get one chance of taking nabilone for a while, one chance of taking placebo for a while, and we see which one works better. So agitation did improve significantly during the nabilone phase, where your agitation score went down compared to the placebo phase. And that was statistically significant. About 47% of people responded during nabilone, and 23% responded during their placebo phase. And response here is having at least minimal improvement judged by a clinician. The second study that was run recently, instead of using THC, used a rich cannabidiol oil, so a rich CBD oil. So it had lots of CBD, but it also had THC. It's in about a 30-to-1 ratio. So the average dose used was about 500 milligrams of CBD, but it had a whack of THC in it. It had 22 milligrams of THC when they got the CBD dose that high. It's kind of like a contaminant because they extracted it. So it's a CBD oil, but you get a lot of THC. They had 60 people. They were older adults, 79, and about 60% female. And here's what happened. They had about 60% of people improve on CBD oil and about 30% on placebo. More kind of improved on the drug, depending on what statistics they did. It was either statistically significant or it wasn't quite significant if they used the proper correction that they were supposed to use. So people have questions whether it's statistically significant or not. But what it did do is there was a decline in agitation, and you can see that that's at week 16. So it took a long time, people have commented, for these two to actually separate. So the placebo group was on top of the CBD THC group, the drug group, for a long time, up to 3 months before they separated. And people have also commented that just having a 4-point difference on that particular scale isn't really clinically significant. So people have talked about that, about this study as well. For safety, there were more dropouts with the active drug, including 2 deaths with the active drug, and there were more side effects with the active drug. And about half of people had reported sleepiness, almost half confusion and disorientation, and about a third of them decreased memory. So you can see some of the effects that giving this high dose is having from this particular trial. And one that's coming soon that a colleague shared with me is the dronabinol study. Dronabinol is another THC capsule that's available in the States, and this was run in the US. So this study is coming soon. It's been presented at conferences so far. So they gave that THC capsule or placebo. So people got one or the other for 3 weeks. And they looked at 2 different agitation scales. So unfortunately, it's statistically significant. It works when you use one scale, and it doesn't quite work when you use the other. This one isn't quite statistically significant. So it improved on one scale, the PAS, the Pittsburgh Agitation Scale, but not on the neuropsychiatric inventory. There was no difference in adverse events between the 2 groups. So that dose was safe and did seem to have an effect. So what about, what's the place in therapy? Does it have one? So I'm wondering, that's all the evidence we have so far for people with agitation and dementia. So for agitation, here's our polling question 3. In persons with Alzheimer's disease, what would you recommend or prescribe? Or if it was you, what would you use? The THC pill that has nabilone in it, through the nabinol one? Would you go to a dispensary and ask for THC from your local dispensary? Would you try medical marijuana to get both of them? Or would you do none of the above. So it looks like we've got almost everyone who is going to vote voted. So I think we can end the poll because I don't see very more coming in and share the results. So it looks like it's almost tied for CBD oil and nabalone, and with dronabinol coming in second. Medical marijuana was last, and none of the above was in between those. So if you picked medical cannabis use is growing among older Canadians. And this is a study that my postdoc did, and he looked at data that we got from a medical cannabis provider who had dispensaries across Canada. And remember that in Canada, it was legalized in 2018. So this is before legalization and this is after. And these numbers are the proportion of people who are older Canadians compared to everyone else. So it used to be about under 20%, but then it's been about a third to a quarter of people since it was legalized. So the proportion of older adults and the absolute numbers has increased. When you look at almost 10,000 older adults who are taking it, the primary reason they're taking it is because of pain. 5,000 of them came in for follow-up, and they reported, so they're the people who kept using it, right? So it's a bias sample. They're the people who didn't kind of drop out. The adverse events that they reported were dry mouth, drowsiness, and dizziness. So they're using it despite that. And they reported improvements in pain compared to no worsening, no change, sleep, and mood. So in the people who were using it, mostly for pain, that's what they reported. So there's also evidence that THC is being used for agitation in dementia from dispensaries. This is a chart review, and they look through charts for dispensary obtained THC, so THC only, and they looked for 50 charts for persons with moderate dementia. And one of the most popular reasons for recommending it was for agitation, 40%. And then after that, a little bit of irritability, being emotionally labile, anxiety, and insomnia. Emotionally labile, of course, means you're crying 1 minute and happy the next. They mostly were using a really low dose, 2.5 milligrams, which remember the other study had like 22.5 milligrams. So it was 10 times higher. So most used a low dose, 2.5 milligrams, very low, or a smaller proportion used 5 milligrams. Almost 80% of the care partners reported improved neuropsychiatric symptoms, which up here included agitation in about 40%. And interestingly, 60% of them said that they were able to decrease or discontinue the antipsychotic use. And that graph's here. 0% increased their dose of antipsychotics. 40% had no change. That dose remained the same. 15% of people could decrease their dose, and 45% were able to stop the antipsychotic completely. For risks, 10% adverse reactions, and those included dizziness, worsening of agitation in some people, and worsening of paranoia. So we do see those psychotic effects, delusions and hallucinations, and paranoia can be one of those. But of course, anything that's going to work has side effects. This shows cannabis-related emergency department, so the EDs, the emergency department visits, which have increased among older adults. And this is from California. They looked at all cannabis-related ED visits, and they looked only in older adults. They were able to get data from all of the acute care hospitals in California. And they looked from 2005 to 2019, and medical and recreational use was legalized there in 2016. And they found that the rate increased, that's the rate of ED visits, from 21 per 100,000 visits to almost 400 per 100,000 ED visits. So that's almost a 2,000% relative increase. And they found that the people who already had higher medical comorbidities, so they already had a lot of other diseases that had been diagnosed, had the highest rate of ED visits and the largest increase. So there's with the legalization, they're getting a lot more emergency department visits because of cannabis. And then for data in Canada, we know that cannabis poisonings have increased in older Canadians. And this is a study that looked at 2,300 emergency department visits for cannabis poisoning in older adults. And you'll see that in that study, 151 of them were in people with dementia. So this graph shows here the cannabis poisonings, and these blue dots are just the number of all-cause emergency department visits. Because if your emergency department visits go down, of course, it can look like your cannabis poisonings are going down, but really all visits are going down. So you adjust it by the total number of visits to get that proportion. So here shows you after cannabis was legalized, the rate of emergency department visits for cannabis poisoning increased almost 2 times. And after edible cannabis was legalized, again, the rate of emergency department visits increased 3 times versus this baseline again. So edibles are not any more safe than cannabis. So there is that warning. Part of the reason for, why these edibles and cannabis might be leading to this is there's variability in medical cannabis. There's plant variability, even within one cultivar, it can have different amounts of THC and CBD. There's all the minor cannabinoids out of those, 350 different, combinations that can change. And depending on how you harvest it, you can get different variations. You can get variations because you process it differently. And so it's difficult to always know the exact contents. To prove that, someone looked at 75 samples of edible medical cannabis and they analyzed them, and they found that only 17% were accurately labeled, 60% overlabeled for THC, 23% underlabeled. Only 60% had a detectable level of CBD, and only 13 products had the CBD content even labeled. So you don't really necessarily know what you're getting. So moving forward, I showed you the first Nabalone trial. We are running a larger and longer trial. You shouldn't change your clinical practice based on 38 people who tried Nabalone in a very small trial. So we're aiming for 112 participants. They have Alzheimer's disease, dementia, they have agitation, and they'll be given either Nabalone or placebo for 9 weeks. Recruitment's ongoing, and we're at about 64%, and it's being run at Sunnybrook, Calgary, Ontario Shores, CAMH, and London. And here are the leaders of those study sites. And the one I wanted to talk about a bit more today was the COMET trial, because you can see that no one's really looked at CBD oil that's been purified, because the one study had CBD oil, but it had a whole whack of THC. So that's the COMET trial. It stands for Cannabidiol Agitation Medication Intervention Trial, so the COMIT. It's a crossover trial, like that first one where everyone gets to try the medication and everyone gets to try the placebo, and we compare. Same group of people, Alzheimer's disease, dementia, diagnosed clinically, meet criteria for agitation. Instead of giving cannabidiol CBD oil, we've got it in a capsule form, because if you start chugging a lot of oil, it gives you GI side effects. So you don't want to have diarrhea because you're taking so much of this oil. So we have capsules, and the good part is the capsules, if you've ever tried to work with someone who's agitated, sometimes it's easier, especially when they have advanced dementia, to have a sprinkle. You can open this capsule and sprinkle it on applesauce and they can swallow it, as opposed to trying to get someone to drink oil. So recruitment for this one is just beginning. We've got our first 5 patients who are running the trial, so we're excited. And for this one, we're aiming for 40. So for this COMET trial, we want to assess the safety and efficacy, because we want to compare it to placebo, right, of pure CBD for agitation and Alzheimer's disease. The inclusion criteria are feelings of irritability, restlessness, fidgeting or pacing, difficulty cooperating with others, and frustration or anger where you wouldn't have had it before. And it is currently running. We have 2 sites up and running, Sunnybrook and Ontario Shores, and Calgary, CAMH, and London Health Sciences Centre are all coming on board soon. They're in the last phases of getting activated. We're looking for people at least 55 years old. They have to have moderate to severe Alzheimer's disease, clinically significant agitation. If you're on medications for Alzheimer's disease, you have to be on a stable dose, because we don't want other medications to change during the trial, because then we don't know what's causing any benefits or any lack of benefits. We have to have a primary care partner who brings you to trials, and of course, the primary carer and the participant, as much as possible, have to give informed consent. So now I'm going to ask a loaded question. In clinical trials treating agitation, about what proportion of patients improve when they receive placebo? 5%, 15%, 25%, or 35%? So we've got most people coming in around with the 15%. So I'll end the poll and just share the results. So 5%, 21% people said the lowest, 45% gave 15%, about a quarter of people said 25%, and 11% said 35%. So there's a whole range of placebo responses, and it depends how well you've done with your psychosocial interventions ahead of time. So I just want to remind you, for clinical trials and placebo, the 12-week Harmony trial to treat agitation, they looked at 350 Alzheimer's disease people with persons with dementia with agitation. There was a decline in agitation in both groups, and it was equal. So being in a clinical trial and getting the medical workup acts like a psychosocial intervention. And we talked about the importance of a psychosocial intervention. So the decline was the exact same. And then in the 12-week Simbad trial, that was mirtazapine for agitation in 204 persons with Alzheimer's disease, dementia, and agitation. There was again a decline in agitation in both groups, but the placebo group had better quality of life. That's why it's not only important to have the placebo group to have some measure of just what the psychosocial intervention aspect of a trial is, but sometimes the placebo group does better. So if you just looked at this and looked at the drug group, you'd say, yeah, agitation is getting better, but actually, if they were on placebo, it's the psychosocial intervention that's helping. And in fact, their quality of life was better without the side effects caused by this particular medication. So that's why when we say efficacy, we know it works, and we know it works because of the medication. So in summary, agitation is common and it's persistent in those with Alzheimer's disease, and we know it has a large negative impact. The current therapies that we have modest efficacy and or poor safety. There is a rationale, a pharmacologic rationale for the use of cannabinoids, but there's limited studies that have assessed it for agitation. The recent trials that we do have do show some promise. They show some efficacy so that they work above placebo, but there's concerns around sedation and other dose-related effects. So further research is underway to find out, does it really work? Who does it work in? Who benefits and who doesn't benefit? And just exactly whether we should be using THC in what dose, or CBD, or a combination. And these are the QR codes. This one here is for the COMET study, and this one here is for the Nabalin study. And we can share those at the end of the presentation, but they're also both on the TDRA website that you heard about. So I just want to thank you for listening, thank my lab, my collaborators, and especially the persons with dementia and their care partners who participate in our research, as well as the funders that are shown here. Thank you very much, and I guess we have time for some questions, so I'll stop sharing.
Thank you so much for all of that. I did want to let people to know that I have posted the evaluation link there below in the chat window. This is extremely helpful for us to know what your needs are as we continue to build out these TDRA updates and research webinar series. I'm also just going to quickly encourage everyone that if you're interested in research, please do consider participating in research. It's really with your participation that we are able to get information to continue to better understand. There is some questions here that gonna ask. So the first question is, for the information that you presented, is it specific to clinically significant agitation, or is it only referring to specific agitated behaviors?
It is all for people who would meet diagnostic criteria for agitation. So it would be clinically important agitation as opposed to very mild agitation where the person might be fairly easily redirected.
And then the next two is really around non-pharmacological approaches. So the first one around massage therapy, is it specifically during the period of agitation, or is it in between agitation episodes that it's most helpful?
The massage therapy evidence that I've seen are in between. So they get regular massage therapy.
And then similar note, does regular exercise also reduce agitation?
Yeah, regular exercise has been shown to be good for neuropsychiatric symptoms in general, so agitation and apathy and all those. And I think it has a small effect on agitation. A lot of the psychosocial interventions for agitation have occurred more in long-term care facilities than in people living in the community, I guess because it's easier to recruit people than to get them one by one. And a lot of people in long-term care facilities aren't able necessarily to participate in a real exercise interventions. So I don't think there's been any really good studies that have looked at an exercise intervention in people in the community. But I know that Dallas Sites ran a study just on parks, taking people to parks. So a little bit of exercise, but just coming to the park and being outside and sitting on a bench. And that had an important effect on agitation as well. So I believe those results are coming up in a publication soon.
Great. The next one is more of a comment. You had talked about how THC could be used or the many effort ways. So THC can be used as an anti-nausea, but there can be a hyperemesis syndrome, which can be of great concern in older adults due to dehydration from constant vomiting. So that was just a comment.
Yeah, that's a good comment. Thank you. It goes both ways. Nabilone that we used is on the market for nausea and vomiting associated with chemotherapy. So that is on the market for that. But yes, you can also have vomiting, especially with high doses. So it does both.
So the next question is around the study. Does it include people who are living with severe Alzheimer's disease?
Absolutely. That's one of our target groups. We're taking people who are living in the community, and we're also taking people who are in acute care, and we're taking people who are living in long-term care facilities as well with severe. Because the first study was a small study only at one site, and before the other reason is you want to look across different sites so that your findings aren't just specific to people who are, ours was done in a veterans facility. So it was done in basically mostly 90-year-old males who were veterans living in a veterans facility. So now we've opened it up to be able to answer the question, does it work in the community? Does it work in people who are admitted to an acute care hospital? And does it work for people also in long-term care facilities besides ours?
So this one is a tricky one. It's related to your poll of the I would recommend or use. So the question was turned back to you. Which one would you recommend to try?
Oh, that's an easy question. We're not ready for prime time yet. We need more research. We have one small Nabilone trial. It's promising. I guess if I was desperate, we would try Nabilone first. Dronabinol isn't available in Canada, but it's similar, and it shows it also shows a signal. So I would tend to right now, if I had to say nothing's available for prime time, but I would certainly try a THC capsule. I wouldn't use the CBD oil on top of the really high dose of THC because I think that, we had side effects. They said that the two deaths weren't related to the medication, but there were 2 deaths in their active group, and there was a lot of confusion and paranoia. So I definitely wouldn't use that. And I worry about just using medical marijuana, although there's that small study that said that really low doses of THC from a dispensary worked. But again, I worry about that because the dose can change, and that's really hard. So right now, I would wait to see. I would how about participate, send your patients to clinical trials, and hopefully in another 2 years, we can answer the question. What I didn't present about the clinical trials is we look at a bunch of clinical biomarkers as well as blood-based biomarkers, and we're hoping to be able to move for this phase towards precision medicine as well.
We have time for, I think, 2 more questions. So this one is, I was told that CBD oil without any THC in it is less effective than CBD oil with a minor amount of THC to activate the CBD receptors in the brain. Is this correct?
Yeah, so CBD it depends on the dose. Everything depends on the dose. The higher the dose of CBD, then it does modulate those receptors. So if you give a high enough dose of CBD, you start working on those receptors, but then you get the side effects. If you have a whiff of a dose of THC, then you start hitting those receptors. But if that dose gets too high, then you have a lot of side effects from that too. So just like drinking alcohol, it all depends on dose, right? So it depends on what dose you're using and how much the blend is. And you saw in the study with the really high doses that that was becoming problematic. Now, there was also the commonly held belief that if you had THC and CBD together, that CBD meant that you could use higher doses of THC. And I didn't show you, but a recent study that came out that fixed the dose of THC to 10 milligrams and then kept adding more and more and more CBD to see if giving CBD actually helped with those THC side effects. And it didn't. They increased the dose to the common ratios that you would find in a dispensary, and it was not able to overcome the word finding difficulties, the cognitive effects that you had with THC, and the kind of delusions and hallucinations that you had with THC. So when it was done in a real clinical trial in a controlled setting, that wasn't actually true.
You so much for your time, for presenting such great information. I can see in the feedback that people thought this presentation was excellent. On that note, would you be willing or able to share the slides with me so that I could share them with those who have participated today?
Absolutely, I'm happy to.
Okay, perfect. So I will be
I
sending
guess
out
I
a
couldn't say
copy.
no when you asked me in front of everyone too, but I was already planning on doing that.
So for everyone who's attended, I will be sending to your email a copy of Dr. Lanto's slides. For anyone who's sort of interested in watching it again, maybe there's some information that you weren't quite sure about and you wanted to revisit, this recording will be available on both the AST YouTube channel as well as the TDRA website in a couple days. We just want to make sure that the recording quality is good. Any edits that we do need to remove are removed before we share it. So it should be available in a few days' time. You will also be able to, on both websites, be able to see all of our previous TDRA webinar recordings if you're interested to see what other research has been presented out there. And I want to thank Natalie. She has also provided the links to both the COMET study as well as the Nabalone study for those who are interested in looking to finding out more. So I would like to thank everyone for the time that you spent with us. I hope you found this information interesting and helpful, and we look forward to seeing you at a future one. I don't know if Natalie, we've started planning if you have an indication of when the next one will be.
Yeah, the next one will be in September, but I don't have the exact date yet. But if you've attended this one, you'll get a notification for the next one in September.
Thank you very
Thanks so
much.
much for inviting me.
Thank you. Thank you, Dr. Langton. Thank you to everyone who attended. And thanks, Julie.
Bye now.
Bye.
Bye-bye.